we have senior radiation oncologist Dr. Suneetha from Aster International Institute of Onco, Bangalore, who is trained in this extensively in Italy, Spain, and then she has this Ioert machine from SIT Sardina, not the one which is the old Ioert intra beam from Calcis, which just gives an X-ray, and now as per the Astro and Estro guideline, they are no longer to be used outside a clinical trial, because there is a lot of recurrence from them, and now if you want to do Ioert, it has to be electron based intraoperative linear accelerator. So it's a very interesting topic. So because it's something new, she's going to cover both from basic to advanced to recent advances. Thank you very much, Suneetha, for accepting our invitation, and over to you, please.
Thank you, sir. Thank you for that nice introduction. Good morning, everyone. I'll be starting with intraoperative. Before going to intraoperative electron radiation therapy, I'll give a brief introduction of intraoperative radiation therapy. See, electron radiation therapy is a part in that intraoperative radiation therapy. As the name suggests, intraoperative radiation therapy, we deliver the radiation, adjuvant radiation, inside the OT when you open up the tumor bed. So this can be delivered by different means. This is not a new technology, as Dr. Somsekhar mentioned. So it's been practiced since 1960s, but in different forms, like either the linear accelerator was stationed inside the OT and the bunker sort of OT was prepared, so which the cost of the facility used to go up. So only few centers can afford to have those facilities in their hospitals. Or else patient operation theater and linear accelerators were adjacent to each other. So patient after the OT was moved into a linac room and they were treated with the radiation, and then again they were moved into OT and surgery was continued, which had lot of complications like anesthesia related complication. OT time would go up while transporting the patient, the risk of transporting the patient, all those things were high. Because of that, it had not gained much popularity because of these technical problems. With the introduction of the miniaturized linacs with self-shielding, again intraoperative radiation therapy started gaining momentum, and now with electrons being introduced with different energies in the same machine with minimal shielding requirement, it is been taking a plunge again in the recent years. So intraoperative radiation therapy as of now, we can use it both with KV X-rays and then the electrons. What is a problem with, as Dr. Somsekhar was mentioning, problem with KV X-rays linear accelerators is they use very low energy X-rays, like example 25 to 50 KV X-rays is used here for the radiation, whereas in linear accelerators we use mega voltage 6 MV, 10 MV or 15 MV X-rays for the treatment, whereas in intraop it is just 25 to 50 kV. The range of those X-rays is just 0.5 to 1 centimeter. Maximum range we can treat with these 50 kV X-rays is about 1 centimeter. So when we have a thicker tumor bed, so we will not be able to get a better dose distribution or a uniform dose distribution with these X-ray machines. So hence came these electrons, where the machines are equipped with different energies of X-ray electrons, where we will be able to treat the tumor bed in a better way. So this was how the intraoperative electron radiation therapy has been introduced. So now going forward, so intraoperative electron radiation therapy can be used both as a primary modality of treatment in the primary management of the malignancies and also in the salvage settings. So approximately about 90 centers worldwide are using Ioert facilities, including X-rays and then the electrons. So because of the few centers using these techniques, we don't have much of randomized control studies to give us the evidence regarding this. So most of the evidence comes either in the form of case series from the individual institutes or pooled analysis or meta-analysis, that sort of evidence we have for Ioert. So in one of the largest Italian meta-analysis, which includes about 1,000 and odd patients which were treated with Ioert, 77% of the primary tumors were treated and about 23 were only recurrent tumors, and the intent of treatment was curative in about 98% of the cases and palliative in only about 2% of the cases. Coming to the site distribution, majority of them were gastrointestinal malignancies, where we feel that dose escalation with external beam alone is not enough. Those were the cases where the majority of Ioert or Ioert treatments were used. Second commonest being the sarcomas. So what are the advantages of Ioert? In Ioert, we can directly visualize the tumor bed. When the surgeon removes the tumor and retracts the surrounding structures, the OARs and the surrounding structures, we can directly visualize the area of interest or the tumor bed. So there is always the less chance of geographic miss. We cannot miss anything over there, especially in case of breast and all those things where we do oncoplastic surgeries and rotational flaps and all the clips and then the tumor bed. The chances of these clips and tumor beds being migrated after the oncoplastic intervention. So Ioert is usually performed before any oncoplastic intervention. That is, as soon as the tumor is removed, the bed is usually irradiated after retracting the OARs. So here we are giving very high dose of radiation to the tumor bed at the time of surgery when organs are retracted or shielded. So it is like high dose of radiation to the tumor bed and very minimal or zero radiation to the surrounding critical structures. So thereby achieving a best therapeutic ratio whatever we can achieve in any of the radiation modalities here. So where zero radiation we cannot give in any of the external beam radiation modalities or any other modalities, because here we are able to retract them during the surgery. So the dose can be even as low as zero dose in the electron radiation therapy. So other hypotheses which they have put forward is, so during the surgery lot of seroma and the plasma is secreted into the tumor cavity, which has lot of cytokines which induces this proliferative cascade, so which promotes the proliferation of the microscopic cells which are present in this tumor microenvironment. Surgery and then the adjuvant radiation. Usually adjuvant radiation we give it after 4 to 6 weeks of surgery. Because of this proliferative cascade, there is a chance of repopulation of these microscopic cells which are present in this tumor bed, and the number of cells which have to be targeted with radiation, adjuvant radiation at a later date might be high. So when we give very high dose of radiation during the surgery, so we can negate this proliferative cascade so that prevent the repopulation of the cells during this waiting period for adjuvant radiation. And one more advantage is during the surgery, we all know that radiobiologically oxygenated tissues respond better to radiation. So post-op, because of the clipping of the vessels and all those things, the tumor bed will have lesser oxygenation. So the effect of external radiation will be less when compared to during the surgery. A good oxygenated tissue will respond better to radiation. These are the factors which have give better advantage to the intraoperative radiation compared to the external beam radiation in the later part of the treatment. So these are the few sites, 5 important sites which I will be discussing today. The rectum, sarcomas, which are the commonest sites which have been treated. Pancreas and the breast is gaining importance nowadays after the APBI guidelines which have come up, and oligorecurrences. Coming to the rectal cancers, these are the most frequent cancers treated with the Ioert. So in especially the T3, T4 tumors, potentially locally advanced rectal cancers and potentially resectable cancers are the rectal cancers where the Ioert is indicated. Even in case of T4 tumors, on about 15% of the T4 tumors, we might not be able to achieve R0 resection even after neoadjuvant chemotherapy or neoadjuvant chemoradiation therapy. And positive margin is one of the negative predictive factor for the local recurrence. The more the positive margin, the more the chances of local recurrence. We all know that. So these are the cases where Ioert boost can help in negating this positive margin effect or the improving the local control. So we all know that the potential sites of recurrence in case of rectal cancers are presacral space and the lateral pelvic wall. So these areas can be boosted with electron beam radiation during the OT, and we can get the same amount of local control as high as with the other rectal cancers without the positive margin. So the flow of treatment would be like this: preoperative chemoradiation followed by resection 4 to 6 weeks of the treatment, and along with electron boost during the surgery. So the dose of Ioert boost ranges between 10 to 12.5 gray, 10 to 20 gray. So in the negative margin, in the setting of negative margins, we usually give 10 to 12.5 gray. In R1 resection, it is 12.5 to 15 gray. With R2 resection, it is 15 to 20 gray. This is actually followed by, this is prior to this, we would have given external beam radiation of 45 to 50 gray, followed by this boost. In the standard treatment modalities, whatever we are practicing, this delivering such high doses was impossible with the external beam radiation because of the constraints, the surrounding normal tissue constraints like the surrounding small bowel and bladder, which used to preclude the delivery of such high doses to the tumor bed. So these are some of the studies where they have shown excellent local control with Ioert, addition of Ioert in case of CA rectums. That is, most of them were T4 lesions where they had, even with a positive margin, they had a local control, a 5-year local control of up to 50 to 60% in case of positive margin. Whereas in negative margin, the local control rates were as high as 98% with the addition of Ioert to the surgery. In case of recurrent tumors, we all know that the local recurrences in rectum, especially in case of presacral region, is the commonest mode of failure. And re-irradiation is a challenge in these places, especially the pelvic region. So here also we can escalate the dose by adding Ioert boost. So the re-irradiation to a moderate dose of about 25 to 35 gray with external beam radiation, followed by surgery, and then intraoperative electron boost will give a better local control when compared to all these patients would have been either, if you feel that they are not potentially resectable or you are going to get a positive margin, most of them would have been dismissed as palliative cases. Now even those cases we can think of cure here because we can escalate the dose of radiation with Ioert. So the Ioert boost doses will be same as previously mentioned. That is, in case of R0 resection, it is going to be 10 to 12 gray, R1 resection 12 to 15 gray, R2 resection up to 20 gray we can go. So this allows for dose escalation. The more the dose escalated, the local control will be better. So these are some of the studies where they have shown very good local control even in the case of recurrent cases to a tune of about 80% at 5 years. 80% of local control with R0 resection in case of recurrent CA rectum, and with about 50 to 60% local control in R1 resection with the addition of Ioert to surgery in recurrent rectal cancers. Am I not audible? Hello? The second commonest cancer which is treated with Ioert is sarcomas. We all know that sarcomas have been, we have been using brachytherapy as a local modality of radiation in case of sarcomas. So the indications for sarcomas being high grade tumor, close or positive margin, tumor size more than 5 centimeter, depth, deeply located tumors, and locally recurrent tumors. The sarcomas, we can treat it in both preoperatively or postoperatively. preoperative radiation is preferred in case of sarcomas because the size of the bulk of the tumor, the sarcomas usually we get very large tumors, especially in case of retroperitoneal sarcomas. The bulk of the tumor itself has pushed the normal organs at risk to the away from the tumor bed side. So we will be able to achieve lesser dose to the OARs because of the tumor bulk itself in the external beam setting. So usually preoperative radiation is the preferred modality here. So the treatment flow will be external beam radiation of 40 to 50 gray, followed by surgery after 4 to 6 weeks of the external beam radiation with the Ioert boost ranging from 10 to 20 gray depending upon the margin status. In the other modality, other sequence which we can follow is preoperative Ioert, that is surgery followed by Ioert immediately depending upon the margin 15 to 20 gray, followed by EBRT at a later stage 4 to 6 weeks after surgery, and Ioert boost the external adjuvant radiation of about 40 to 45 gray can be delivered. So the treatment in retroperitoneal sarcomas mainly will be targeted. We don't target whole of the tumor bed region, only the attachment wherever the sarcoma was attached to the critical structure, that area will be targeted. It is not like 10 to 20 centimeter if sarcoma is retroperitoneal sarcoma is present. Whole of that area will not be targeted with Ioert. Only the stump wherever the attachment of the sarcoma was there, that area will be targeted with Ioert. Doses again remaining the same. Suspected positive close margin 10 to 12.5 gray. Suspected involved margin 12 to 15 gray, and gross residual disease we go up to 20 gray, 15 to 20 gray. So what are the benefits of Ioert over external beam radiation? Here we will be irradiating very small volume of the tumor bed with no margins. So the nerves and the skin can be pushed away from the tumor bed here. Especially the skin we can protect. If the tumor is very close to the skin, we can shield the skin edges with the lead shields, and even the nerves. If the nerve is present, if a major nerve is present in the tumor bed, we can even shield those nerves. We are not able to retract those nerves away from the tumor bed. We can even shield those nerves with lead strips and then deliver Ioert, safe dose of Ioert. So this reduces lead toxicities, which results in better functional and limb preservation, functional outcome and better limb preservation rates. And 5-year local controls are also more with the Ioert along with surgery. So in retroperitoneal, this is the region where Ioert has proven beyond doubt, even in terms of overall survival. With the addition of Ioert to the surgery, so there is a drastic difference in the local control, 5-year local control. For example, in one of the studies, it's 20% versus 60% with addition of Ioert. And we have even seen overall survival benefit in case of retroperitoneal sarcomas. Because we all know that retroperitoneal sarcomas and pancreas are the difficult sites to treat in case of GI malignancies or abdominal malignancies because of the location of the tumor itself. Lot of critical structures over there, kidneys, liver, bowel loops, so which prevent us to give very high dose of radiation in those areas, because we have to always follow that juggling between the OAR doses and then the tumor dose. So we have to give very high dose of radiation to the tumor, whereas as low radiation to the critical structures. The OAR doses itself, the tolerance of the bowel loops are only 50 gray, so we will not be able to escalate the dose more than 50 gray in these sites, especially retroperitoneal sarcomas and the pancreatic tumors. So we restrict our doses to only about 50 to 54 gray in whatever advanced technology we have in EBRT. So what happens with Ioert is we are able to escalate the dose and give very good local control in these tumors, which eventually will reflect in overall survival. So coming to the next site, that the breast, with the advent of APBI, Ioert has been included as one of the modalities which can be selected in the treatment of these patients. So the advantages of Ioert is utmost precision in delivery of the boost or the utmost precision in delivery of the adjuvant radiation without any geographic miss, which we see during the external beam radiation, and high biological effective dose with the electron beams, and very high dose delivered in a single fraction during a very short period of time. And we have very good cosmetic outcome here because we can spare the skin completely and very small volume of the breast is irradiated when compared to other APBI techniques. See, APBI can be delivered either with external beam radiation or with brachytherapy, or even the intraoperative method is also accepted. As mentioned earlier, with the KV X-rays, we will not be able to have a better penetration. So the electron will have a better penetration when compared to the KV X-rays in the form of in intraoperative settings. When we come to brachytherapy and external beam radiation, we will be irradiating unnecessarily the more larger volumes of the breast volume when we are doing APBI. External RT, almost rather than the tumor bed, whole of that quadrant will receive low dose of radiation when we treat them with APBI. So in electron beam radiation, we will be specifically targeting the tumor bed. So the dictum here is 1 centimeter. If the tumor size is 3 centimeter, we have to use the applicator size 1 centimeter, just more than the tumor bed size. So the only 4 centimeter diameter of the tissue will be irradiated, and the dose for APBI, that is a single fraction of treatment, will be 21 gray. When we are using such high dose of radiation, we have to protect the underlying ribs and the thoracic cage, because the chances of rib fracture at a later days, one of the late toxicities which we get to see with intraoperative radiation therapy is rib fracture in case of breast cancers. So to prevent that, we have to place this protective shield. Different size protective shields are available along with the applicator. So depending upon the applicator size and then the tumor bed size, these shields are also chosen, and these shields are placed in between the chest wall and then the tumor bed. So, and then the radiation is delivered. So the selection of the applicator size and the shield size is like if the tumor bed is 3 centimeter, our applicator will be 1 centimeter more than the tumor bed, that is 4 centimeter applicator we are going to choose. And if the applicator size is 4 centimeter, the shield is going to be 5 centimeter. Again 1 centimeter more than the applicator side, so that there is no scatter along the edges of this applicator. So it blocks totally whatever, almost zero dose to the chest wall, and maximal dose only to the tumor bed can be delivered. This is in case of APBI, where we deliver just single fraction of radiation in the OT itself and finish off with the adjuvant radiation inside the OT itself. So they need not have to come for external RT again. So if it is not, these patients should be carefully selected depending upon the Astro and then the Jekestro guidelines. So carefully selected patients only we will be able to deliver such high dose of 21 gray. Otherwise, it can be used as a boost. So in the as the primary modality in the adjuvant setting, or as a boost along with external RT. So what we can do inside the OT itself, we can boost the tumor bed to a dose of 9 to 12 gray, and then followed by external beam radiation of whole breast. This can be used for all the cases. All cases we can use this so that we have a better local control. The higher dose of tumor bed dose escalation can be done with intraoperative electron radiation therapy. So these are the guidelines which we need to follow, very stringent guidelines from the Astro guidelines. More than 50 years, T1 tumors are only screening detected tumors, less than 2.5 centimeter, and negative margins are the suitable candidates for APBI. According to Jekestro, again more than 50 years, no DCIS or no lobular component are allowed here. Tumor size less than 3 centimeter, negative margins, unicentric tumor or unifocal tumors, no NBI, no extensive intraductal component, node negative are the cases which are preferred. Post-neoadjuvant therapy, usually we don't go for, because those are the advanced cases or the triple negative cases. We usually don't go for single fraction of treatment. So these are the requirements for the single fraction of treatment. 21 gray adjuvant intraoperative electron radiation therapy inside the OT itself, and that is the end of the adjuvant radiation. In the OT itself, we can finish off the adjuvant radiation. So, but we'll have to follow these stringent guidelines and be careful with when we are delivering such high doses such as 21 gray. So there comes the utilization of the TPS and the treatment planning systems, so which I will be going to show in my next slides. So the other area which we were talking about is pancreas. As I was mentioning when I was talking about sarcomas, this is again a critical structures, critical situation. The pancreas is located in such critical site where we have kidneys on either side and liver and small bowel all around. So we are not able to escalate the dose more than 50 or 54 gray in the external beam radiation setup. So we all know that curative dose of radiation for any malignancies up to 70, more than 70 gray we have to deliver. Why we are able to achieve such higher cure rates in head and neck malignancies in cervical cancers are, we are going to deliver 70, or in cervical cancers BED of up to 80-90 gray is delivered with addition of brachytherapy. So we are, even with stage 3 and stage 4 diseases, we are having a better local control, better overall survival in these cases, because we are escalating the dose, which was not possible in case of pancreas because of the organ constraints, that is the OAR constraints which we were supposed to achieve. So we always balance between the side effects and then the therapeutic the advantages. So when we give OAR doses the more priority, our doses used to come down, and we never used to cross 50 or 54 gray in case of pancreas, which was never enough for a better local control. With addition of intraoperative electron radiation therapy, so we have been seeing more and more local control rates, which eventually will get transferred into overall better OAR survivals. So pancreas, a borderline resectable or unresectable pancreatic cancers are treated with external beam can be treated with Ioert. So usually pre-op external beam radiation along with chemotherapy to a dose of 40 to 50 gray, followed by Ioert boost during the surgery. Whatever the surgeon can remove, he tries to remove it, and wherever there is attachment, that is R0 resection or R1 resection, even in case of R1 resection, with boosting with the Ioert, we get a better local control in these tumors. So these are some of the studies where they have shown better local control with the addition of Ioert to the pancreatic cancer. And in pancreas, we also have they have also used Ioert in palliative setting, because we know the uncontrollable backache or the severe backache is one of the problems which is faced by many of these locally advanced diseases, which cannot be controlled by any form of medications, or they'll be having such severe backache in case of pancreatic cancers. So we can use this even in those palliative settings to give very high dose of single fraction of radiation, which will control the disease to some extent and also reduces this pain to a very good and give a very good quality of life to those patients. So other than this, Ioert can be used, it's a boon in case of recurrent tumors in the salvage setting where we have oligometastasis, and in case of gynecological cancers where we have a central recurrence or nodal recurrences, these can be targeted. The nodes can be addressed with surgery and then boosted. Wherever the node was there, that area can be boosted with Ioert followed by external beam radiation at a later stage. Recurrent retroperitoneal sarcomas, recurrent RCCs, and para-aortic recurrences in case of gastrointestinal and gynec malignancies, recurrent head and neck cancers. So all these are the cases where Ioert has been tried and it has got a very good good local control rate, even in the salvage setting or even in the recurrent setting, because re-irradiation is coming up in a big way, because most of our patients are now living for a longer period of time and they are coming back with recurrences after 5 years, after 10 years also. We are getting to see recurrences in the local region. So, and re-irradiation really becomes a challenge only with external radiation, where we will not be able to escalate the doses to very the curative dosage. This thing. So IOERT comes as a better aid in this situation, and they have even been tried in case of glioblastomas, where we have very poor local control rates or very poor survival rates. They have been trying it in phase 2 trials using IOERT in case of glioblastomas also. So coming to the toxicities, what are the toxicities which we can expect with IOERT? Because we are retracting all the critical structures, we are very sure that we are not hitting the critical structures with IOERT. In case, invariably, if some nerve or some vessel, major vessel is there in the tumor bed which we are not able to retract, those can be shielded with the lead strips. So the common toxicities which we experience is neuropathy, which is the dose limiting toxicities. Very less with moderate doses of 10 to 12 gray. That is a boost dose what we give. So around 3% is the incidence of neuropathy with the 12 gray, which increases to, when we increase the dose to more than 50 gray, the incidence of neuropathy goes on increasing. Bone necrosis and fracture, which can be prevented by using the shields, especially in case of breast malignancies. Muscle fibrosis, and in GI we should be careful about the bowel, and we should retract the small bowel as away from the field as possible. Vesicovaginal fistulas, enteric fistulas and perforation have been reported, and gynec malignancies, urethral strictures and urethral dysfunctions have been seen. It is more so when the urethra is in the field. So we have to identify the structure and retract it away from the field and then reduce it. In that way we can reduce the urethral strictures and urethral dysfunction. And other complications like lymphedema, delayed wound healing, dehiscence and abscess formation, which are again the surgical related, and which can be managed with a better sterilization techniques and better handling of the applicators. And so these are the toxicities which are commonly reported. Coming to the technique, so the this is the LIAC. It has different components in it. This is the LIAC machine which we have installed in our hospital recently. We have finished the installation procedure and we are waiting for AERB approval. See, these machines in our country have been grouped as linear accelerators. Even though they don't have high energy X-rays, just they are the machines with electron, different energies of electron. Here we have energies of electron ranging from 6 MeV, 8 MeV, 10 MeV and 12 MeV X-rays. Four energies of electrons are available in this machine, and we all know that the range of electron is very less. If I show you the previous slide. Yeah, this is a 6 MeV dose distribution looks like this. This is going to be my 90% isodose curve, which will encompass the tumor bed, and this is going to be my 50% isodose curve, which is about for 6 MeV X-ray, 6 MeV electron. If I give an example, the R90, that is the 90% range, is at 1.7 centimeter, whereas R50, that is 50% isodose line, will be at the depth of about 2.2 centimeter, and when we go to 2.9 centimeter, there is almost zero dose. So such is a drastic dose fall off what we see in electron, which allows us in better sparing of the OARs and escalating the dose to the tumor bed. So even though these machines are only equipped with electrons because of some regulatory these things, because these are the first few machines which have been imported to our country, still these machines have been grouped as a linear accelerator machines, and very stringent protocols have been followed by AERB. As such, it doesn't require any special requirement for a OT room. So we don't require any special shielding for the OT as we get to see in linear accelerator, the bunker and all those things are not required here. Only this thing is we have to have a lead door with an interlock, and we have to have a monitor like the glass window to monitor the patient when all of us move out of the OT while delivering the radiation. These are the only few requirements in the OT. So it can be installed in a normal OT itself. And this is the LIAC machine which has 4 energies of electron, and this is the applicator. The applicator comes in different sizes ranging from 3 centimeter to 10 centimeter with different bevel angles, 0 bevel, 15 bevel, 30 bevel and 45 bevel. So combining all these permutations and combinations, that is sizes ranging from 3 to 10 centimeter and bevel angles ranging from 0 to 45 degree, about 60 odd applicators are available for us for intraoperative, to deliver intraoperative electron radiation therapy. We can choose the applicator depending upon the size of the tumor bed, the location of the tumor bed, the tilt, whether it is a straight surface, whether it is a flat surface or whether it is a curved surface. So depending on that, we can choose the beveling of the applicator. So, and the beam stopper, this is very important here because electrons transverse directly along this applicator and only point of exit is through the posteriorly, that is below, that it directly passes through and through. So this is about 300 to 400 kg of lead shield which has to be placed below the area of interest from where the electrons are going to pass through. So this absorbs all the scatter radiation which is going to go from below, and this acts as a protection for the electron. So if the OT is in the ground floor, you don't have any occupancy below the OT, you don't even require this shielding. Because our OT is in 3rd floor, we need this because there is an occupancy below our OT. We need this beam stopper when we are using the intraoperative electron radiation. This becomes a mandatory. If OT is in ground floor or in the basement, there is no occupancy below the OT, even there is no need to use this beam stopper. So arm holder, which I am going to, and then the treatment console. Treatment console will be outside the OT, which is stationed outside the OT. After we all move out of the OT, we are going to enter the monitoring units from there and then start the delivery of the treatment. So the LIAC and the console are interconnected. They speak to each other, whereas the TPS is an independent system. TPS is not connected to the machine. TPS is not connected to the console. It is an independent system which helps us in different ways. So which I'm going to tell you in that. This is a robotic arm which is attached to the OT table, to which we can attach the applicator. And once the applicator is positioned on the tumor bed, it is going to remain stationary in that position. And once we lock the applicator, we just release this, it is going to get locked. Once it is locked in that position, it is not going to move at all. So we can easily dock, we can easily bring the machine from this end and then dock the head in this direction. So this helps in older machines, whatever we had seen in some of the training centers didn't have this robotic arm. So where they used to manually hold this applicator in the tumor bed and then they used to try to dock, which was making it very difficult. The docking procedure was becoming very difficult because of the movement during the docking. So this stops that movement and aids in better docking of the intraoperative system. So the TPS. TPS is the recent addition into this intraoperative electron system. Our license number is, I think, 05. So I feel there are only very few centers which are used. I think Dr. Somshekhar can enlighten this because we feel that we are the 5th person to procure it. So we have to confirm it from Saldona because we had not seen this system during the training also. Whenever we went to Europe also, most of the center didn't had this thing. So what is this TPS is? It has a localizer everywhere. These are the localizer. There is an infrared camera which is stationed 1 centimeter from the operation table, which reads the surrounding in the operative area. It also will be capturing the operative bed. It captures the location of the table. It captures the location of the tumor bed. It captures the location of the applicator. The applicator will also have a localizer like this. So it captures the location of that local applicator, and it also captures the location of the ultrasound probe. So this TPS comes with an ultrasound probe and an infrared camera and these localizers. So the flow of the procedure will be like this. Once you remove the tumor bed is exposed, organs at risk and the skin will be retracted away from the tumor bed, and depending upon the surgeon is going to demarcate, this is going to be my tumor bed location, or this is going to be my tumor bed size, which can be either done with the help of clips, or we can use the dies also to demarcate the tumor bed. So once the demarcation of the tumor bed is done, we use this ultrasound probe. There are two different sizes of ultrasound probe available depending upon the size of the tumor bed. Smaller tumor bed, we can use a smaller probe, and the bigger tumor for the sarcomas and all, we have a bigger probe. So two sizes of ultrasound probes are available. So with the help of ultrasound probe, we are going to scan that tumor bed area and then locate the exact tumor bed on the ultrasound also, which get transferred to the TPS. On the TPS, we are going to see the size of the tumor bed, the thickness of the tumor bed we are going to appreciate, and depending on that, we are going to select the size of the applicator, the beveled edge of the applicator, and then the thickness of the tumor bed. All those things will be fed into this software which is there in the TPS. Once we feed all these things into the TPS, whether we are going to use the shield, we are not using the shield, what is the size of the tumor bed, what is the size of the applicator, what is the bevel edge of the applicator, what is the energy of the electron which I intend to use in this case. All these things will be fed into this software. Once we feed this into the software, we are going to get a dose distribution. The TPS is going to give me a dose distribution like this. Depending on that, we can even draw OARs. Up to 2 OARs can be drawn on the TPS. So if any critical structure are there, I can even draw those OARs and see how much the dose the OAR is receiving. So depending on that, either if I feel that there is an underdosing, I'm going to go increase my energy of electron. If I have used the 6 MeV electrons and I want the dose distribution till here, I'm not getting the dose in the required area, I'm going to increase the energy of the electron and get the better dose distribution. If I feel that more of radiation is going to the OAR or unnecessary radiation is going to go beyond the tumor bed, I'm going to decrease the energy of electrons which we intend to use and get a next dose distribution. So we can see prior to delivery itself what is going to be my dose distribution in the patient and select the required electron energy. After we select all these parameters, or I can even change the size of the applicator. If I feel that beveled edge is not giving me that much of this thing, 15-degree bevel is not giving me the required the dose distribution, I can increase the beveling to 45 degree or I can decrease the beveling to 15 degree. So depending on the different permutations and combinations can be done, and we can visualize the dose distribution. Once I am sure that the dose distribution whatever is showing is according to our requirement, we go for MU calculation. So once we calculate this MU, it is going to give, this is the MU which has to be delivered depending on the size of the applicator, tumor bed, the thickness of the tumor, bevel. All these factors will be taken into consideration, and it's going to give us the MU calculation. And also the TPS also gives the angle from which the LIAC has to move in and it has to be docked in. So that also will be displayed on the TPS, which aids in the smoother docking of the intraoperative system. Docking itself is a major procedure here which takes the major time of the intraoperative treatment. So the dockings become easier. We have some assistance in docking. The time which taken for the intraoperative treatment can be reduced. So the TPS helps in all these things. It localizes the tumor bed in relation to the OAR because we are using the ultrasound here. It calculates the three-dimensional volume of the tumor as well as 2 OARs. Up to 2 OARs we can use it and draw on the ultrasound, and it aids in the positioning of the applicator. So it also gives like which angle the applicator has to be positioned. All those information we get it from the TPS. It gives us the color wash. This we call it as the dose color wash. So it gives the dose color wash and aids in MU calculation. Once this is done, the TPS function is finished, and I told you it is an independent system. It is not connected to the machine. It is not connected to the console. So we get the MU calculation from this, and then once the MU is calculated, all of us will move out of the OT. Everybody will be cleared except for the patient. Nobody is allowed to stay inside when the treatment is going on. And the MU calculation, whatever we have got from the TPS, will be entered in the console, and then the machine is turned on. Once the machine is turned on, the treatment will be delivered. So the patient can be monitored during the treatment through the glass window, and we have CCTV cameras also, which is connected to the vital parameters, and the patient can be monitored even through the CCTV cameras. These are the two methods by which we can monitor the patient during the treatment. And even the treatment is going to be very short. We can deliver 10 gray of radiation in 1 minute. The machine has a capability to deliver 10 gray in 1 minute for 20 gray. If we treat 21 gray, that way for the breast and all those things, it is just 2 minutes. It is such a short period of time we'll be able to deliver. So it is basically patient is left alone inside the OT for very small period of time, to a period of 1 minute or 2 minutes. Even during that minute also, we will be able to monitor the patient through these two systems, that is the window and then the CCTV monitors. Once the delivery is complete, everybody moves in and the system is undocked and the machine is moved back, and the surgeon continues with his further surgery. So this is going to be the how the OT looks once the patient is docked in. So this is the LIAC, which has moved from the one end to required position. Applicator, which is being positioned onto the tumor bed, and it is locked. Once it is locked, and this is the TPS which they have placed it at this end, OT monitors. So everybody moves out of the OT and then the treatment delivery starts. Thank you. Any questions? I will be just...
Yeah, thank you very much, Dr. Suneetha. So trainees, we have time. You may type your questions, comments in the chat box. Thank you.
I'm not seeing any questions here. Are there any questions? I think chat box. I'm not seeing any questions. Oh, 1 second. Yeah, I think there is a question. MU is monetary units. So we calculate the dose of radiation. The gray is what we report when we give you a summary. MU is the one, monetary units. We call it as monetary units. Is the one which is calculated from the physics, and when we deliver the radiation, we deliver it in MUs. It is for electrons, it's 200 MV, 300 MV, something like that, MUs. So we use those monetary units. It is called as monetary units. Implications of hormonal status and Ki-67 in the Ioert. Yes, triple negatives, as I told you, usually we don't take it because most of the cases they would have gone for neoadjuvant chemotherapy. Ki-67, usually they say lower, less than 20% is the one which, according to the guidelines, this is not a criteria. But when we are starting the facility, when we are using it for the first time, even we want to be on a lesser aggressive side. So we usually go with low Ki index tumors which have low chances of recurrence, and very good prognostic cases we select for, especially the single fraction 21 gray dose. We will be careful when we are selecting the cases. I think how will you decide R0 and R1 resection and adjacent dose on intra-op? R0, R1 resection, the surgeon themselves will tell you. Most of the time they will only tell you, so I'm not able to get a clearance in this area. This is the area we might be able to have positive margins. So depending on that, we will be able to deliver. Otherwise, if you have a frozen facility, that is a better this thing. Adjacent dose in intra-op, we have to keep it as minimal as possible because we know the tolerance of each organ. If we are intending to do along with external RT, because we would have delivered our dose tolerance to the adjacent structures through external beam radiation. So in intra-op, because we are delivering very high dose of radiation here, so we should keep the dose to the OAS as low as possible. If possible, 0. Where do we place the shield during the breast radiation? It has to be placed above the chest wall, between the chest wall and then the tumor bed. Yes, R1 is microscopic. I told you just now. It is frozen if you get a frozen report. I think these are the few questions. What material shield is used in head and neck cancers? Head and neck cancers, we don't go with upfront intraoperative radiation therapy. It is usually used as a boost in case of recurrent cases. Head and neck cancers, only in the recurrent settings, especially the nodal recurrence, will be treating with intraoperative electron radiation therapy. In those cases, it is only the boosting those positive nodal regions. So the dose we are going to use in head and neck cancer to boost those positive nodal regions is going to be between 10 to 12 gray only. So when we are using such low doses, there is no necessity for the shielding. If you are worried about your carotids or some major named nerve which is passing through that area can be shielded with a lead strip. Depending upon the energy of the electron we use, we have some calculations which will calculate the thickness of the lead shield, which is used to reduce the dose to that area to about 50%, reduce the dose to that area to 80%. Depending upon that, we can select the thickness of the material. Preferably, it is a lead or a cerobend. Cerobend is a material which we use it for shieldings. So lead is also a malleable metal which we can use it for shielding purpose. Thyroid, actually there is the role of radiation itself is very less, especially in case of well differentiated thyroid. So it is radioiodine. I have not come across any literature regarding this. Extremity sarcomas, bone can tolerate very high doses of radiation. These fractures and all those things are common when we deliver high doses of radiation like 21 gray. This is a problem only in case of breast where we are using very high dose of radiation and very thin flat bone. The ribs are the flat bones which are very thin. So the chances of fracture is more in those cases because we are delivering high dose of 21 gray and the bone is also very thin and it is a flat bone. Whereas in case of extremity sarcomas, those are the thick cortical bones which can tolerate very high dose of radiation. And the dose of radiation, intraoperative radiation, whatever we are going to give is going to be only as a boost, which is restricted to about 10 to 15 gray, maximum of 10 to 15 gray. So we need not have to worry about the bone unless directly we are hitting the bone here. Our whole thickness of the bone will not be involved in treatment of extremity sarcomas. Only a portion of the bone will be getting irradiated. Where else can I see I am seeing the questions in chat box.
Yes, Dr. Suneetha, there are questions in the chat box only.
Okay, Q&A, there are no. Yeah, I think I have answered all the questions.
Yes, so if no more questions, thank you very much, Dr. Suneetha, for the presentation, and thank you very much, trainees, for joining the session.
Thank you very much, NBE, and thanks to Dr. Somsekhar sir for giving me this opportunity to interact with the students.